So labor and delivery, this is something that we manage as an obstetrician and midwife. We are torn between how to manage the most important hours of pregnancy. There are many paths and consensus, as we will share, and there are guides at the same time that confuse us. So we are moving towards evidence-based medicine, yet we have to take into account many cultural and societal expectations. Whatever we have to do has to be clinically feasible, especially 3 in the morning with a minimal crew and unionized nursing staff. I don't know if you know what I mean by unionized nursing staff. In the US, a lot of nursing units are unionized, so there's really not a whole lot of autonomy that we can actually, we can work with the staff. But what we want at the end of the day is only one thing, is to get a healthy woman through the tribulation of labor and end up with a healthy and happy mother and baby. Why is that so hard? In the long journey of 40 weeks of pregnancy, this really short final stage of pregnancy is probably the most stressful time for expecting mother as well as for doctors and midwives. First stage of labor averages between 7 and 13 hours for nullipra, and 5 to 8 hours in multipra. And this could be a very, very stress-inducing time indeed. So we want to rely on established and safe guidelines that will help us make the right decisions. We want a simple, digested, and almost like a cookbook medicine, which will help us when we're on call, and again, especially when it's 3 in the morning, and protect us from harms on the way. But we always wonder where this evidence came from and how good are these evidences, and most importantly, can I apply to my patient, and do I believe in them? The challenges that we face is that physiology of labor is still not well defined. We struggle with the definition of labor itself. Then there's a patient's desire, cultural influence, medical legal variation, and of course, our own clinical experience. Recently, our unit, we experienced a pretty severe hypoxic ischemic encephalopathy of completely unknown reason. The only thing that we could have explained is that there was a failed vacuum attempt. And do you think that doctor will ever do a vacuum again in any near future? Probably not. So we, as a clinician, are no longer the captain of the ship. Rather, we are merely an operator who absolutely depend on others' duty and responsibility during these critical hours of pregnancy. We work under the assumption that the framework that we are working on is well-oiled and in tune. And we have to make sure that everybody in the team has the same goal. That is the patient's safety and uneventful delivery of mother and child. So by now, everybody probably is review this paper and contemplating as to this is a new trend and new future for labor management. So this consensus statement came from NIH in the US, and this is a mathematical interpretation based on a retrospective cohort data of a term singleton spontaneous labor of 62,000 women from 19 different hospitals. And they used polynomial regression to drive this new curve. And please don't ask me what polynomial curve means. I have no idea. So most experts require that labor requires uterine contraction and dilatation, and at least of 80% cervical effacement, and somewhere between 4 and 6 centimeters of cervical dilatation. Again, this labor curve, I'm sure many of you are familiar as well as using it now, is based on the seminal work by Dr. Friedman back in the 1950s. And they are still taught in labor ward, in residencies all over the country in the United States. So now that we have a new curve, so which curve do we use or believe? How do we accept the new knowledge and incorporate it into our practice? Freeman's curve on the left was first published in 1955 and has guided literally thousands of OBGYNs and midwives in the US and around the world, and it's literally ingrained in our head. And we know that this was based on first-hand observation, and curve represents the bottom 5th percentile for the population. Not the median, but bottom 5th percentile. The new curve was established, again, based on retrospective cohort data of a much larger population, and they use a different mathematical formulation, maybe a little more complex and requires more statistical knowledge. And I'm sure Professor Robson probably knows about the difference between the two. And there is obviously enough difference in clinical practice. And if you look at the literature, there are more labor curves to consider, and they have different slopes and different starting point. And maximum slope of about 3 centimeters per hour has been proposed. And again, 1.2 centimeter dilatation at the bottom 5th percentile. And I noticed that Professor Ferrazzi will be here tomorrow. But this is, I saw this article and the literature recently that this is a graphical illustration of about 300 women, a very homogeneous population in his hospital who are going into spontaneous labor. And he measured how long it takes from going 1 centimeter of cervical dilatation. And it put it on a graph, and the bottom is the bottom 10th percentile, and the top line is the 97th percentile. But if you look at individual patient population, there's really no way you can predict how one individual patient's labor going to occur. So you could, patient who started out labor at 4 centimeter could be rapidly dilated in a matter of less than 1 hour. Well, it could take as long as 9 hours for a nullipar. So he concluded there's really no way to predict how an individual's labor is going to progress based on an examination. And he stated that cervical dilatation from 6 centimeters to complete may take as short as 30 minutes for some patient, as long as 3 hours and 37 minutes. And all these patients achieved a term spontaneous delivery with a normal neonatal outcome. So if we put his curve along other published labor curve, you can see that the other curves are a little bit faster, and the Freeman's curve has this famous deceleration phase. And I think this is a lot of discussion that's taking place, and whether this deceleration phase exists or not, because oftentimes we don't get to examine patients who went from 8 centimeter to 9 to complete dilatation, and this is a point that gets missed very often during clinical examination. Regardless, all of these labor curves are showing sort of a trend that we can probably use it as a guideline. So what was the purpose of this publication? The main purpose for this new labor curve is to really suggest and try to decrease the rise in cesarean section in the United States. 34% in the United States C-section were due to labor arrest. And oftentimes in the ward, there's a huge clinical management variation, time of the day, the experience of the attending, how there's a lot of non-clinical factors that go into making a decision of primary cesarean section for labor arrest. And I think this is a good idea, and I think something that we need to kind of follow. But then, not all evidences are perfect, as you know, and just because it's published in a very respected journal does not mean we have to follow them to the dot. And mainly because some of the evidences are based on a randomized controlled trial that have very rigid protocols. And we discussed it earlier that our patients do not necessarily follow those exact randomized controlled protocol. And oftentimes, meta-analysis that we tend to look are really too heterogeneous to come to any conclusion. And the population that's been studied may not apply to your population. And this whole notion of the labor curve is a mathematically derived curve. And it's not, again, I don't have the expertise to say this is a biological phenomenon that we're extrapolating using mathematics. And does that mean that this is how the nature is meant to be? And I think that's an argument that we can make another time. And again, there's no single unifying guideline to follow. But what's important is that there's a local consensus. So whatever that you do in your ward, I think it's important to come up with a consensus and then follow, look at your outcome and follow the review. And again, a lot has been discussed by Professor Robson and everybody during the earlier meeting. And there are such things as a obstetrical safety program that are available in the literature. So how good are the evidences that we see? And this is a meta-analysis of things that we do in labor ward. As a simple thing, diagnosing active labor, pelvimetry, a lot of different kind of clinical decision-making process. And most of them, if not all of them, have a very poor quality of data. So just because and if you collect these to make a meta-analysis, that meta-analysis is not going to be a high quality in nature. And same thing goes for cesarean section. There, do we give, how do we close? What layer do we close? And antibodies before and after, manual extraction of the placenta, washing the subcutaneous layers. And there are many, many different variations of clinical practice, but all of them really don't have a good evidence base. So you can kind of look back and kind of use the guideline as to, is the evidence that I'm looking at, is that good enough to follow? Now, a lot of evidences, by the time they get published, they become outdated. Average systematic review are 5 years old, and by the time they're about 7% of the reviews are already outdated by the time they get published. So with that in mind, if you look at the obstetrical care consensus, the quality of evidence that they propose is their level 1B. So I think this is a good guideline that we can take it to our own unit. And then if you want to challenge it or modify it, I think you can do so, but do it in a consistent manner. So the main point of the new labor guideline is a prolonged latent phase, defined as more than 20 hours of primate and 14 hours for multiprise, is not an indication for cesarean section for that purpose. And slow first stage of labor is not an indication for cesarean section. And they proposed a 6 centimeter as a cervical dilatation as the start of active phase. An arrest of dilatation is diagnosed when the patient is at least 6 centimeters dilated, ruptured, more than 4 hours of adequate uterine contractions, or 6 hours of pitocin with inadequate contraction. Again, this is a good starting point that you can use in your unit to set up a local guideline. And how, if you set up your own guideline, this unit at Yale New Haven Hospital show that by doing the same thing consistently, you can decrease the adverse outcomes in that particular unit. So Chris Petker published this data, and it showed that they came up with 40 different documents that are unique to their unit, and everybody follow that protocol. And by doing so, malpractice and adverse outcome litigation, the amount of payout has decreased substantially over the course of a really short duration of time. So really, it's about consensus. And I think consensus for your own unit, the way you practice, and it has to be it's an amalgamation between evidences that you collect in the literature and then the way you practice. So the way we practice in our unit may not apply to your unit, and the way that NIH consensus came up will be a completely different population, and the way they practice and may not exactly applicable for your own unit. So if you come up with your own consensus, that is ideal, but I know at the same time it's very difficult, because our unit, we sit down and go over different clinical management protocols, and it's so difficult to have 12 partners to come up with the same consensus. Recently, we had to come up with a diagnosis, gestational diabetes, and we just could not come up with even the very basic diagnosis of gestational diabetes. And we had to have 2 or 3 different meetings, and that's how challenging it is. So when it comes to documentation, what do we actually document? This paper came up in PubMed that, what causes the really large medical liability in obstetrics? And there are 4 things. Is obviously CTG, failure to identifying CTG abnormality, poor management of placental abruption and uterine rupture, failure to prevent shoulder dystocia, and then operative delivery that's gone bad. So from the inexperience or the operator-dependent procedures that has gone bad. So these are the 4 main areas. They came from legal colleagues of ours. It's, the judges who looked at cases in Belgium and France thought that these were the important area that we need to focus to minimize liability. So in order to have safe birth, they proposed that you need a well-educated provider. So that's a high achieving goal. And you need that provider to recognize the obstetrical risk or pathology that you're dealing with. And appropriate choice of medical intervention, whether you want to do an instrumental delivery or cesarean section, you need expertise to do so. And the person doing it has to have adequate training. So these were the important aspects in minimizing liability. And I think documentation should be kind of around these areas that you need to focus. So when it comes to documenting, what do we document? And previous speaker mentioned about if you don't document anything, that's probably a suicide. It's very dangerous, and I have to wholeheartedly agree. But documentation alone, I don't think will save you from trouble. You need to think about the expertise and what you're dealing with, and your thought process needs to be documented carefully. So whatever you're documenting, you have to support your action. You have to document what are the obstetrical risk factors that you're dealing with. And this may or may not be obvious. It's just because a woman is a primate and spontaneous labor, that patient may have additional risk factors that you may not have recognized initially. You're going to document factors that may potentially influence labor curve, and document your clear understanding of fetal heart tracing abnormality. And you got to document your reason for your action, and I believe that you have to document your action and explain it to your patient. And I think patient needs to be on board of what your plan is and why you're doing what you're doing. So what are the factors that may influence labor curve? And again, I'm no expert in labor curve, but I think these are factors: the patient's age, parity, their previous obstetrical history, BMI certainly, because BMI tends to exaggerate the head descent. So if a higher BMI woman, we feel like the head is, lower than you assume, and in fact the head is much higher. Obviously, fetal size, fetal head position, whether it's an OP and OA, and we went through a forceps delivery session today, and sometimes that's not very obvious. You cannot, on a molded head, it's very difficult to really check what the fetal head position is. and clinical pelvimetry before patients, if the head is engaged, and that's very poorly documented in the literature, and also documented patients' desire, requests, and birth plans. And I'm sure in Italy, a lot of patients in the United States, they want certain things, certain way for their labor to ensue, and it may not make any medical sense, but that seems to be happening. So my time is getting up. So when you're documenting, you want to do a cooperative documentation with your nursing staff, resident fellows, midwives attending together. You want to support your documentations together, and if there's a conflict between what your nurse is documenting and what you're documenting, obviously that's going to be a very serious trouble in case something goes bad. So, and patient consent, I think, is especially if you're involving a special circumstance such as a VBAC or water birth or a intermittent external fetal monitoring, I think you may need to document additional information based on the risk that additional risk that you may have to take. This is an interesting study that compared the quality or the compliance of documentation among resident, midwives, and attending physician, and guess who had the best compliance? Midwives, of course. And senior attending physician were the worst in documenting the important obstetrical factors that may affect labor curve. So finally, I think the first author of the new labor curve really cautioned us with all the controversies that, and stated that any labor curve is illustrative and may not be instructive in managing labor because of variations in individual labor pattern and large error in measuring cervical dilatation. So I think that's a very important point. All these data are extrapolated from some individual's examination that may or may not be identical to your own. So it's a guideline, and it's not a 10 commandment. So in conclusion, evidence is available for a specific population. I think safety first, safety for mom, baby, and care for providers. Guidelines are guidelines. There are good guidelines that we want to follow, and there are not so good guidelines that we may or may not follow to the teeth. New labor curves are mathematical derived guidelines to reduce cesarean section, and we have to use it like it is. And I think local consensus are probably more meaningful, applicable to your population. Obstetrical risk factor must be documented in advance, and patient's wish must be documented, in my opinion. And then at the end of it, whatever you do it, you review to see what you did really made a difference in the outcome. Thank you very much.
Grazie Joe, ti pregherei di sederti qui con noi.